The Snellen chart is used for the far vision acuity test. Position the patient 20 feet away from the Snellen chart and ask her to read from the topmost or biggest letter up until the smallest ones below. Test one eye at a time while covering the other eye with an occluder shield or any opaque card or object, but do not use the patient's hand as cover. Choose the lowest line wherein majority of the letters are read accurately, with more than 50% of the line read accurately plus 2, and record her visual acuity as a fraction. Repeat procedure for the other eye and interpret the results. The numerator of the fraction is the distance at which the chart is placed. The denominator is the distance at which the letter could be recognized with normal acuity. For example, 10 over 200. Note if this is done with or without corrected lenses for comparison. If the patient is having a hard time to read the letters at 20 feet, you may bring her closer to 10 feet, adjusting 2 feet at a time until she can see the topmost letter clearly.
Okay po, mas hindi po tayo nagsisquint ngayon. Check po ulit natin ang kabilang mata para mag-read po natin.
E, F, P, T, O, Z, L, P, E, D, P, E, C, F.
Establish a patient-doctor relationship. Ask for consent. This can either be written or oral. Clearly state the instructions to the patient.
Tapos po, tatakpan niyo ang inyong isang mata, tapos saka babasahin niyo po hanggang kaya. Tapos po, kabilang mata naman. Tapos babasahin niyo po ulit. Pagkatapos po nito, nakasalamin naman. Tapos, tatakpan ulit yung isang mata bago basahin at yung kabila naman po ulit. Okay po ba? Malinaw po ba?
Malinaw, nakalinaw po.
Sige po, ito po ang tatakpan yung mata.
Test one eye at a time by covering the other.
5, 6,
Hold the Jaeger chart around 14 inches away from the patient.
3, 4,
First, test the patient's vision without correction lenses.
na. Hindi na kaya.
Sige po, kabilang mata naman po.
5, 6, 9, 4, 7, 3, 2, 3, 4. Yun lang po. Ang dami lang po. Hindi na rin po kaya.
Okay po, ngayon naman po nakasalamin.
Then, ask the patient to wear his or her correction lenses if applicable before reading the Jaeger chart again.
5, 6, 9, 4, 7, 8, 2, 3, 4, 3, 6, 9.
Thank the patient for cooperating.
I-record ko na lamang po. Salamat po.
Record and interpret the results. Stand in front of the patient sitting on the examination table. Inspect for symmetry or alignment of eyes. Inspect any lid movement such as blinking every few seconds, lid twitching, or jiggling of the eye. Inspect brows for texture, alopecia or loss, extraordinary growth of hair, and presence of seborrhea. Inspect the eyelashes if it curves outward as expected. Note any matting, loss or misdirected lashes, and any infection occurring in the glands around the eyelash hair follicles. Note any marked eversion of the edge of the lower eyelid, exposing the palpebral conjunctiva. Note any marked inward turning of the eyelid. Note crusting, redness, and swelling of the eyelid margins. Instruct the patient to look up. Pull down the lower lid of each eye to expose the inferior sclera and the lower palpebral conjunctiva. Using a pen light, inspect the sclera and the lower palpebral conjunctiva of the lower eyeball for color, swelling, and vascularity. Instruct the patient to look down. Pull up the upper lid of each eye to expose the superior sclera and conjunctiva. Using a pen light, inspect the sclera and the conjunctiva of the upper eyeball for color, vascularity, and swelling.
Maraming salamat po.
Pupillary examination is an important part of the ophthalmologic exam as it is able to detect abnormalities in the ophthalmologic reflexes and is therefore able to detect abnormalities in the nerves, specifically optic and oculomotor nerve. Pupillary examination is conducted in a dim-lit room to clearly visualize the pupils. In conducting the pupillary examination, the physician should first check the size, shape, and symmetry of both pupils. After this, we can proceed to the light reaction. First, instruct the patient to look into distance and not focus on the light. Shine bright light into each pupil from a slightly lateral position to the patient's line of vision and check for pupillary constriction in the eye being shined into. This is called the direct reaction. Note the consensual response of the opposite pupil constricting simultaneously with the pupil being tested. Repeat steps to the other eye. After this, physician should perform the swinging light test and should note whether there are differences between the direct and consensual response. After performing the light reaction, the physician should now proceed with accommodation and convergence reaction. First, instruct the patient to focus on your index finger. Finger should be approximately 2 feet from the patient's eyes. Move the finger toward the patient's eyes while maintaining it in a center position. Note for the pupillary constriction and the crossing of eyes as the finger moves closer. Evaluate the pupillary response for both eyes.
For testing peripheral acuity, we do a confrontation testing. Have the patient seated in front of you for about 1 meter away. Eyes of the patient and physician should be at the same level. A screening must be done first. To do screening test, both eyes must be uncovered first and the physician should assess if the patient can see the physician's finger located on the inferonasal, inferotemporal, superinasal, and superiotemporal regions. Make sure the patient is focused on your face. Let patient cover left eye and focus at your face. Examiner should close his right eye to use visual field of left as basis. For dynamic testing, slowly move your wiggling fingers in different quadrants and ask him to count while looking straight. For static method, show various numbers of fingers in different quadrants and ask him to count them while looking straight. Repeat testing on the right eye. Examiner should close his left eye to use visual field of right as basis. The patient has been instructed to keep her head still. She is then told to follow the finger of the doctor using only her eyes. If the patient moves her head while doing the test, the doctor may hold the patient's chin if allowed by the patient. The doctor checks for the 6 cardinal fields of gaze using an X or H movement, pausing at each end of the movement. Observe for nystagmic beats and jerking nystagmus. Better visualization of the eye is done by holding the eyelid of the patient while performing the test.
Ophthalmoscope examination. Instruct patient to fix their eyes on a distant point in the distance throughout the exam and to try not to move their eyes. Hold the ophthalmoscope with your right hand when examining the patient's right eye and the left hand for the left eye, such that your middle finger is resting on the lower front aspect of the head of the ophthalmoscope. Place your left hand on the patient's forehead with the left thumb over the patient's right eyebrow to assist stability. Apply a gentle upward traction on the top eyelid with the left thumb. From an angle of about 15 to 20 degrees lateral to the patient's line of vision, shine the ophthalmoscope towards the pupil of the right eye and look through the ophthalmoscope's viewing hole. Note for orange glow in pupil, the red reflex, and check for opacities blocking the red reflex. Move closer to patient's eye while slowly rotating the adjustment wheel of the ophthalmoscope using the index finger up or down until the structures become clear. Examine retina, optic disc, retinal vessels, peripheral retina, and macular area. Describes disc margin, reports copper disc ratio, AV ratio, absence or presence of hemorrhages, exudates, cotton wool spots, copper wiring, AV nicking. Report and interpret findings.